Okay, so some of this stuff we've already talked about through the Nagel's Rule and GT-PAL videos. So there are slides in here that you guys can go back and review, but you also have those videos too, okay? When we talk about the journey to parenthood, we talk about the pre-pregnancy period, where we start to prepare the body for pregnancy. We talk about conception, and we're going to make sure that the patient doesn't have any STIs. We talked about some of this stuff already in the repro lecture. The antepartum period is the pregnancy. Okay, so the whole time they're pregnant until they go into labor, it's called antepartum. And that is broken down into 3 trimesters. The intrapartum period is labor. And that's broken down into different stages and phases, which we'll talk about next time. Then you have the postpartum period. So that's from the delivery of the placenta all the way past or up to a year after birth. Okay. And we also care for the newborn. And newborn is considered from birth up to 28 days old. And so over the course of the OB lectures, we're going to learn about all of these different things. In the preconception period, we do recommend that the patient goes to see an OB. Okay, the OB, they can meet the OB and see if they even like them, right? Mm-hmm. Or they could go to a certified nurse midwife as well. Okay, certified nurse midwives are nurse practitioners that are trained to deliver babies. We want them to start seeing a provider at least 3 months before. And they're going to start eating healthy. Okay? They're going to have a regular exercise routine. We want them to take daily folate supplements or folic acid supplements starting 3 months before. And we want at least 400 micrograms per day of folate or folic acid. 400 micrograms per day. And usually that 400 micrograms is in any over-the-counter prenatal vitamin. So as long as they start taking those prenatal vitamins, that's going to give them enough folate to prevent neural tube defects. Neural tube defects you guys learned about, yeah? Mm-hmm. Yes. So like spina bifida, cleft palate, all of those things. And so that's what we're doing. So why do we take folate supplements? Excellent. You're going to have to know that for sure. We're sure that she doesn't have any STIs and protect her from them by educating her. Avoid harmful chemicals, metals, or other toxic substances. Stay up to date with their current vaccinations. Sometimes, if they like don't have MMR, if they need to take that vaccine, we'll have them not get pregnant for 3 months after that. So we would want to, at least 3 months before, make sure she's current on all of her vaccinations. And because we can't have that one during pregnancy, so we would have to give it after pregnancy to ensure that she wouldn't get sick and pass it off to the newborn. We want them to start managing and reducing stress. First, stop smoking. What does smoking do? It decreases oxygen. How? It's a vasoconstrictor, right? Yeah. So That decreases oxygen and blood flow to the fetus and can cause a lot of issues. So stop smoking and alcohol. Yeah.
So weirdly, one of my friends who got pregnant by accident and then she was like addicted to vaping, the doctor told her she could wait for like a month to like quit. Is that
Should quit as soon as possible.
Okay.
Yeah.
I was like, you should see another doctor.
Sorry. Handing out your OB books. These are your lab books. Promise me you're going to bring your lab book to lab. Promise and promise. But I want to give them to you now because it has really good study resources in it. Okay?
Bring them to lab and science.
Bring it to OB lab and sim. Okay? This is the cutest lab book you'll ever get. I love you guys. Make sure you put your name on it because when we're in OB lab and sim, you might lose it. We want to make sure it gets back to you. Right. Put your name on it. Don't forget. And don't forget to bring it to lab and sim. Please. We did add a preconception portion. If you've seen this book before. Reproductive care. That's in there because remember, the reproductive system comes into play when we're making babies, right? So that's in there for you guys as well. In the very beginning. Okay, and the last thing that we want them to have done is the genetic carrier screening. Genetic carrier screening can cover like the big ones like Tay-Sachs, cystic fibrosis, sickle cell, all those big ones. Or you can do a genetic carrier screen, which includes, I think nowadays, like up to like 500 different diseases that can be passed to your child. What they do is they test mama's blood, and if she comes back positive as a carrier for anything, then they'll test the sperm donor or the partner's blood. Okay, and if they match, then we know they have a risk of having an offspring with this disease. Okay, if that's the case, what we would do is do IVF, and we'll grow embryos. And then we biopsy those embryos and send them off to the lab to be tested for that specific disorder. And then we would only transfer the ones without it. Okay. And you only have to have that test done once, right? Because it's always what you carry. How conception works. We all know from our repro lecture that once we ovulate, those fimbriae sweep up the egg into the fallopian tube, right? And then we're hoping, because that's what the body wants to do, is reproduce, right? We're hoping there's going to be some sperm. We want the sperm to be in the fallopian tube when the egg is released. Because remember, the egg only lives for 12 to 24 hours. And so we want sperm, lots of sperm, in that fallopian tube in order to fertilize that egg. Okay? Fertilization occurs in the fallopian tube. Where does fertilization occur? In the fallopian tube, right? So it doesn't occur anywhere else but the fallopian tube. Why do I say it a million times? Because you gotta know it, right? So fertilization occurs in the fallopian tube, and then that, if it happens, that egg will turn into one cell, okay, right? Because it has half DNA, right? Half from the mom, half from the sperm. And so it'll turn into one cell, and then it'll divide into two. Two becomes four. We'll talk about that later on in the lecture. Okay. At about 7 days after fertilization, it'll then implant in the uterine line in that endometrium. That nice cozy home for the baby, right? Mm-hmm. This is what an egg looks like. It's actually gray. It's not these like sun colors, right? It's actually gray. It's kind of boring. But they colored it so that you guys can see it a little bit better. This egg is actually the largest cell in the human body. It can actually be seen without a microscope with the naked eye. Okay? That big. This one hasn't been fertilized. This is just an egg, and then there's little sperm here. 1, 2, and 3 little sperm that I can see. Anyway. And so I know that this egg never got fertilized because we need thousands and thousands of sperm to break down that egg and get in. Okay. This outside layer, this yellow layer, is called the corona radiata. These are cells that are attached to the egg that come from the follicle. Okay. Those cells actually attract sperm with a chemical that they release. So all the sperm want to go to that egg, okay? The outside part of the egg is called the zona pellucida. It's a jelly-like layer of the egg that once the sperm start to break down that corona radiata and they get to the zona, the outside shell, it'll release an enzyme to start breaking down that zona so that it can get in. Okay, and it takes hundreds and hundreds of them all together breaking down that zona. Once one gets in, we only want one because we only want half of that DNA, right? We don't want more than one. Once one gets in, a burst of energy happens in that egg and it closes it off to all of the other sperm. So only one can get in, okay? And it creates so much energy that it produces a flash of light when that happens. Pretty cool, right? So where does fertilization happen? In the fallopian tubes. Perfect. This is my friend Sherry. Sherry is an embryologist. And she is performing what's called ICSI, intracellular sperm injection. And so she's taking one good sperm. Remember, we look at the motility and the morphology, trying to find a really good sperm. And she injects it right into an egg for fertilization. Okay, and I like to show you guys this video because we always look in books and we only see flat versions of it. But when you see her inject this egg, you can see how like gelatinous the egg is. It's not like eggs that we have in our fridge, right? It's very gummy, like jelly-like. And so you guys can see not only that, but you can see the difference in the size of the sperm in the egg. You might not be able to hear her very well, but I'll talk it over with you. So she's got that corona radiata around here, right? And the zona is that hard or jelly-like outer layer. Her right here, that's her needle. There's a tiny little sperm right there. Do you see him? See how big of a difference in their size? And she's got these little joysticks that she's moving around to move her needles. So she's going to start getting another needle that's gonna, it's like a vacuum needle. It's gonna suck up that egg for her. Here it comes. So that it holds the egg still when she injects it with that sperm. And then she's gonna turn the egg
so that I can put the sperm inside there. So we want to make sure that that needle is bigger so that it doesn't pull the egg up into it. But
I don't know why
basically,
it
I
comes
want
out
to get
so
it in a
quiet.
really
But
good
she's
spot.
gonna turn the egg. She's gonna
The
look
other
for
thing you
what's
wanna
called
see
the
on
polar
these eggs,
body.
you want to see
You'll
their
see
mature
it won't
eggs.
come up
She
here
just uses those things like they're
in just a second. Right there, see that? This is the polar body, and that tells her that that egg is mature, and so she can use it.
The egg is mature.
Okay.
If that's not there, then it's not a mature egg, and it's not going to allow us
Correct,
to fertilize.
and it won't produce
So we typically
it won't
make sure we use
fertilize.
only mature eggs. All right, so I've got that egg on there. I'm holding it right there.
So we only have one of
Bring
them.
the needle with the sperm up there.
Yep, they'll only
Hopefully
have
all
one.
goes well.
So now she's gonna inject
And
that sperm.
go ahead and enter into the egg.
Look how gummy it is.
I haven't gotten there yet, but
And you can't hurt that egg in any way by doing this
And watch that. See, it still bends around the needle
when you're done.
and I'm trying to make
until
sure
it
I get all
finally
the way
breaks
through.
that zona, that layer.
It's not letting me get in there. There it goes. Very bendy. Yes.
It's like rubber.
And now she's gonna drop it off.
So now I've left that
he's in
sperm in
there.
there. You can see him. Come on back out. Just
And then
keep
she'll put it to a
that sperm
different slide, a spot on the petri dish, inject more, and then they put it in the incubator overnight, and then they look to see if it's fertilized or not. Very cool, right?
So they put more sperm inside of that egg.
membrane. That
Nope, just one. We only want one. Yeah. And so I didn't record, but when she catches those sperm, remember looking for the motility, how fast it moves, how well it moves, and the morphology, its shape. She'll find the best one. And what she does is she takes that little needle, and I know it sounds rude, but she stuns it. So she'll hit the sperm, okay, and it makes it stop moving for her so she can suck it up into the needle. Pretty cool. So, embryology is really fun.
Day? Like,
She does that every day.
how many does she do it?
As many as we get. Yeah, so the eggs will be retrieved from the ovary, and they'll inject as many eggs as they get. Depends on the person and what's going on with their fertility, but they might have a lot, they might have just a couple, or even one. Yeah, so they're gonna watch it grow over the next 5 days, and then 5 to 6 days, and then they'll take a biopsy and they send it to the lab to test to see if those chromosomes are normal to produce a normal pregnancy, or if we had that genetic carrier screen and something came back, they could also test for that specific disorder. So they'll do that biopsy, and then they freeze all of the embryos until we're ready to get all that testing back, which can take like 6 weeks or so. And then we'll build that endometrial lining with estrogen and get it ready. And once it's ready, we'll insert that embryo. Yeah, just one time. Yep. Absolutely. Yeah. That's why they have to be very careful. Yeah. If she wants to donate her embryos, it could go to anybody.
Or she wants to use a surrogate?
So there's a difference between gestational carrier and surrogacy. Surrogacy means you're using your own eggs and they're fertilizing for somebody else. And surrogacy is actually not, and implanted back into you. And surrogacy is actually not, it's against the law in the state of Arizona. Mm-hmm.
Surrogacy is not allowed.
Correct. But gestational carrier, where you use somebody else's egg and somebody else's sperm and it's implanted, is acceptable. So gestational carrier and surrogacy are two very different things, but people use surrogacy as a broad term of it. Does that make sense?
Wait, no, we're confused.
Sorry.
Surrogacy, it's your own egg?
Correct. So the person that's carrying the baby is using their own egg. Mm-hmm.
The other one is like you take the egg from the mom that wants it.
Mm-hmm. Or a donated egg,
Okay.
and it's not her physically, like biologically her
They're
egg.
just a carrier. So they're
Correct.
just carrying just the
Correct.
body. Okay.
Yeah.
So that's the illegal one.
Illegal is using her own egg to be a carrier for somebody else. In Arizona, I don't know only, but in the state of Arizona, you can't do that. Crazy, right?
But she can use somebody else's, she can accept them.
Somebody else's, and carry for somebody else. Yeah. Which doesn't make sense, right? Because you can give your baby up for adoption. But that's why we have to get involved in legislation when we don't agree with things that are happening, right? Yeah. I put this slide in here because I think it's cute, and we're going to talk about what are signs of pregnancy. But this one says, Mike, we really are pregnant. I can't see my toes anymore. And he says, so 5 pregnancy tests, 2 ultrasounds, hearing the heartbeat, and 3 months of nausea didn't convince you, but your toes do. She says, yeah. Which brings me to signs of pregnancy. You have to know these signs of pregnancy. Okay. We have presumptive, probable, and positive. Presumptive or possible is maybe she might be pregnant. Okay, these are subjective signs like amenorrhea, not having your period, nausea, fatigue, sore breasts or breast changes, and frequent urination. Remember that the bladder sits on top of the uterus, right? And so as that pregnancy starts to get heavier, it pushes it on the bladder, which makes the bladder or makes frequent urination in the first trimester. Probable are objective, so presence of HCG in the urine or blood. Maybe, again, still not 100% sure. There are some other things that could cause HCG in the blood, so that's why we don't know 100%. Okay. Uterine growth. You could have fibroids. You could have a molar pregnancy, something like that. So we're not 100% sure. Braxton Hicks contractions. Those are warm-up contractions that you're usually painless, but some people feel that. Again, probably, but we're not sure. Allotment. Allotment is where a provider or a nurse would be checking the cervix of a patient, and we would push on the cervix. And when we push on the cervix, sometimes the little fetal head will float up, and then it'll float back down and tick on our finger. That's called allotment. So when we feel that fetus tick back on our finger, there's probably a fetus in there, but we're not positive yet. Okay. There's some other signs, but I really want you to just know Chadwick sign. Chadwick sign is where, remember you guys when you saw the cervix in the repro lecture, and it was a bright pink color? When there's a pregnancy, the cervix will then turn, and all the tissues surrounding will turn purple. That's Chadwick. Yep. Is where the tissues in the vagina and the cervix turn a purple color instead of that bright pink. Okay. So probably, we're not sure yet. Signs are only done by a provider or a trained professional. And those are the only 100% diagnostic of a pregnancy. So it's objective data noted by an examiner. And it can be visualization of the fetus by ultrasound, Dopplering fetal heart sounds, hearing fetal heart sounds by stethoscope. We have a fetal stethoscope. It's a little bit different than ours. Looks like this. Gravy, right? Put it on the belly, wherever you think the heartbeat is, and I'll teach you how to do that. And then I think they rest their chin on this. I've never used it. We'll have to ask Dr. Wilding. She's used it once. This is how we used to do it before we had doctors. But Dr. Wilding had to use it because her patient didn't want any electronic anything for her pregnancy, so she had to use this one time. And then fetal movements palpable by a trained practitioner. So you can feel that baby moving, or you can see the baby moving as it rotates in the uterus.
We
can't palpate it.
Hmm?
We can't palpate.
You can.
Oh, we can?
Uh-huh. Yep.
It says fetal stethoscope, so is there a difference other than
Yeah,
that one?
this is a fetal
That's
stethoscope.
the only kind? Okay, it's not like a newer one or,
No.
okay.
Yeah.
You can hear
The
it.
newer one is just a Doppler.
Okay.
Okay, know those signs of pregnancy: presumptive, probable, and positive. Terms to know: LMP, you guys know, is last menstrual period. EDD and EDC. EDD, estimated due date. When do we think she's going to have birth or give birth? EDC is estimated date of confinement. It means the same thing as estimated due date. Okay, when do we think she's going to give birth? But that's just an older term. So I wanted to make sure you guys knew that it means estimated due date. Okay, we just don't use it anymore because confinement meant that that woman is confined to this pregnancy and can't do anything else, right? It's kind of rude. So we don't use that word anymore, but you might see it. Every day that the fetus is in the womb is important. And so we count every day of the week. And the due date is when we estimate she's going to be 40 weeks pregnant. Okay? And so when a patient comes to see us, we need to know exactly how far along she is according to the weeks and the days. And as pregnancy gets closer, we can either use a wheel, a pregnancy wheel, which I'll show you in lab. There's actually a slide that has a picture of it too. Or as we're closer to the due date, we can just use the calendar. And I'm going to go just to this tab here. So say her estimated due date is April 30th. She's going to be 40 weeks and 0.7 days on this day. Okay? So her weeks are going to change every Thursday. So if we wanted to find out how far along she is today, what's today? The 12th? The 13th?
The 13th.
Okay. So she's 40 weeks here. Here she's going to be 39 weeks, 38 weeks, 38 weeks, 37 weeks and 6/7, 37 weeks and 5/7, 37 weeks and 4/7 days pregnant today. Does that make sense?
Yes.
Cool. We all know Nagel's rule. I'm going to go past those slides. This is the pregnancy wheel. Oops. Oh, sorry. I didn't change the slide. Okay, this is the pregnancy wheel. And then that's just showing you that calendar that we just went by. So if she was like not close to the due date, we could wheel out her last menstrual period or her due date and figure it out based on today's date. Pregnancy dating, I really just want you to pay attention to menstrual dating. That's where we use the last menstrual period to determine the due date. Don't worry too much about all of this stuff. It just gives you information on when her missed period would be, when you could get a positive urine pregnancy test. Sometimes it's even sooner than the 30 days-ish. And then when we would confirm the pregnancy by ultrasound. Conception dating is only done in IVF when we know for sure. IVF or IUI at fertility, when we know for sure when we conceived that pregnancy. Okay. So when we're counting a 40-week pregnancy, we're going off of that last menstrual period, right? And so that 40 weeks doesn't include those first 2 weeks. Okay. So she hasn't even ovulated yet when we're going off the last menstrual period. So she's technically only pregnant for 38 weeks. Does that make sense? You know G's and P's. More terms. Viability is a pregnancy greater than 20 weeks gestation. Okay. Considered viability. Nowadays, it's better if we're past 24 weeks. We have a better survival rate. Our technology has gotten better and better, and we've had some babies survive before 24 weeks, but typically 20 weeks to 24 weeks is a very low survival rate. We just use that term viability past 20 weeks. Abortion is anything before. You guys all know all that. Miscarriage is medically termed a spontaneous abortion, and then medical termination of pregnancy is an induced abortion or therapeutic abortion, TAB. You know, term and preterm. Post date is after the 41st week, is the 41st week, so 40 and 0/7 to 41 and 6/7. Post term is 42 and 0/7 and beyond. And when we get to post term, the placenta doesn't work as well. It starts to calcify, and it doesn't work as well. So we just want to have an induction and have a baby, so she doesn't run into labor on her own.
So do they normally, do they mostly let it get to 42?
It depends on if the mom just really wants to wait until she spontaneously goes into labor or not. But typically they'll induce at the 40 weeks-ish, depending, yeah.
So sorry, the post
Depending
date
on
is
how it's going.
41. So what is
Post date.
between the 40? Okay, I think I got it.
But for your GT pal, anything after 38 weeks, even if they go to 42, would be a term. Okay. This is breaking down your GT pal for you, which we've done. We already practiced in class. All right, let's take a break. Be back at 50.